that you and the audience may wish to actually bring to our attention and ask that we're not covering, feel free to come to the microphone and we'll take the odd question or two just to enhance the experience for everybody. So gentlemen, we ready? What we'll do is we'll start from the right, so Mojib, you're up, and we'll progress to the left and then swing back again, okay, and cover this. So we'll start with the first case. We've got a 65-year-old female. She presented. She was actually from overseas. She'd recently come to the country and she found her way to our consulting suite to talk about her pain bilaterally, and she was in a wheelchair. This was her presenting images, problems on both left and right sides. So Mojib, obviously I've got another x-ray, but we'll start with this x-ray, and what we really want, your approach as to how you assess the patient, acknowledging that this patient requires surgery, so getting to the crux of the matter, how are you going to proceed?
I'll just check in my initial history and physical clinical assessment that her symptoms are predominantly coming from the hip. There's no associated sacroiliac or spinal.
Let's exclude spine as a cause here. These are all hip problems.
And I assume there's a leg length discrepancy, the right being a bit shorter than the left based on the x-ray.
Yeah.
And you said she's on a wheelchair. Is that something that she's been long or just recently?
It's because she's having difficulty actually ambulating. So she's got to the point where she started utilising a wheelchair because it's just too sore to get around. She can walk short distances of bed to bathroom, but not much more than that.
And what's the range of motion?
Port stiff.
Both of them?
Yeah.
Okay. And I assume sciatic nerve, vascularity, everything is
all intact.
Okay.
Yep.
So with the patient herself, where would she like to start the procedure? Would she more symptomatic on the right or on the left?
They're both equally sore. That's why she's in a wheelchair.
Okay. So basically my approach to her will be a total hip replacement. I'll go with an uncemented variety because that's what I do. And I don't do bilateral simultaneous total hips, so I do them staged, and I'll stage them 3 months apart to avoid the risk of VTE. This is a Crow type 2, so I do anticipate slightly under or uncoverage of the acetabular component, but I try to medialize as much as I can, and I would be okay with about 20 to 30% of the cup if it's left uncovered. Mm-hmm. And then, I will tell her that we would get the leg slightly longer, but that would be matched when we do the contralateral side.
So how are you to decide on which side to do first? You're not going to do bilateral, so which side are you going to do first?
I'll go with her symptoms. If she's absolutely sure, then I'll just ask her choice if she would like me to go with the right or with the left. And
I think the point you just brought up is the fact that doing the stage, she's going to have a major leg length discrepancy, and you need to bring that to their attention.
Yes,
otherwise, it's a complaint.
In the meantime, I'll tell her that we'll be giving her a shoe lift if the discrepancy is wide, much more than a centimeter and a half. Anything about 0.5 centimeter could not be treated with a shoe lift, but anything more than that, definitely she'll need a shoe lift on the shorter side.
Very good. Surgical approach?
I do my hips posteriorly, posterolateral approach.
Mm-hmm. Suri, anything varying to that?
Nothing really. I think this is a dysplastic situation. She has lived for 65 years with the mobility. So slightly higher hip would be acceptable because you can compensate on the opposite side. Won't really try to bring it down to the center of rotation. There's enough sclerotic bone, so I'm not really anticipating problems with the socket fixation. Compensating footwear in the intervening period. Aspirin prophylaxis and mobilization and with support ambulation in the intervening period.
Vijay, is there any role for bilateral in certain patients that present with dual pathology?
I suppose there is, but I'm not fond of that, so I very rarely do that. But I would take on the shorter hip whenever I need to do both in a staged manner. I would do the shorter side first so that the limb length discrepancy isn't that great, and that has worked well in my hands.
Mm-hmm. And your choice of implants?
Choice of the established side standard socket, maybe Pinnacle. I would certainly keep an SROM ready and handy.
So why an SROM?
Sorry?
Why you mentioned the SROM?
Why SROM? So on the femoral side, you may deal with an excessive anteversion. That would be the problem for me. So if I need to, and then they're all very low offset patients as well. And so 65, you usually get a big size stem. So any of the standard stems, the offset may be too high. So I would certainly keep an SROM ready. However, I will try a standard stem first, like a Korai. If it doesn't, then I will use an SROM.
Okay. Dr. Mahanti, we're all talking cementless here. Do you have anything varying? I mean, is there a role for cement here?
Yeah. First of all, I'll try the center of rotation bring down and put the acetabulum in the anatomical position. Acetabulum is dysplastic, but either a jumbo cup or I don't hesitate to put a graft from the head and put an uncemented cup there. And, it depends on what is the anteroposterior diameter of the acetabulum. If acetabulum anteroposterior diameter is good, then I can put a jumbo cup. That's a preferable option. Or else, if it is not too much, then I take a graft from the head and split it and put 2 screws in the direction of the sacroiliac joint so that it is along the, trabeculae, so that graft uptake is better. And it should be within, weight-bearing region so that graft resorption doesn't take place. On the femoral side, it looks straightforward. As Vijay told, that anteversion is a problem, but anteversion, instead of ASRAM, one can use a cemented stem as well in this case, where you can adjust a version as well. So I would prefer either a non-cementless, or if in my country, many patients, they don't afford, and then I can put a hybrid option, putting a cemented stem as well.
Okay. Riaz, when do you consider leaving a cup uncovered? How much uncoverage can you actually tolerate in patients like this? Is there a role for perforated windows to medialise the cup and get better rim fit?
I think you've got to medialise down to the true floor and never more than that. And once you're down to that, so we talked about this yesterday, medialisation. I mean, I just put the cup where it has to go, which is onto the true floor, and then I assess the superior uncoverage. That if it's only a small volume or area of the cup that's uncovered, I quite like the Japanese technique of bone grafting into that area and drilling above the hole and bone grafting in. I'll take the bone graft from the femoral head. If it's a large defect, then I'll either use a trabecular metal or, as just described, screw that head in and use that as a bony augment. Just one comment about the femur, though. The left side looks like it might be a type C, a door type C, so I'll be very unhappy to proceed without actually seeing an X-ray further down, because if that patient really has got an ectatic canal there, then I would certainly consider cementing a prosthesis on the left. The right side looks a bit more straightforward.
Mm-hmm. Anyone else in the panel have anything different to say?
In my hands, this woman would get a bilateral hip replacement. I think that's the best operation for someone who's wheelchair bound and needs instant mobility. The New Zealand Joint Registry has got a paper published currently on bilateral joint replacements, and we've shown that the 60-day mortality rate with simultaneous bilateral hip replacements is no more than single-stage hip replacements. So if you take mortality as a bad result, then and within the first 60 days it's likely to be related to the surgical procedure, then that would suggest that the adverse outcome following bilateral hip replacement is not as bad as some people have thought in the past. Certainly in my hands, my practice, it's about anywhere from 5 to 15% of patients get bilateral hips and bilateral knees. The wrong thing to do in this patient is to do sequential hip replacements early. So if you do a sequential hip replacement within 6 months, the immune system is still primed, and you're then at an added risk of thromboembolic problems. And so that's the wrong thing to do, in my opinion.
Thank you. Thorsten?
Regarding the uncemented, cemented, so I would really think about a cementing technique, and if you use a proper modern cementing technique, I have nothing to say against cementing this patient. Bone quality due to the immobilization seems to be quite poor. We've heard it's a type door C defect, so we can reduce the risk of periprosthetic fracture, we can use the risk of dislocation, and there is nothing against cementation, in my opinion.
Mm-hmm. Tananit, I might just expand a little bit. Can you talk to us about how you prepare a patient in terms of blood products, cross-match, tranexamic acid, and your anticoagulation post-op?
Yeah, usually now, because we very rare to give the blood transfusion. So this is a couple of years for the knee replacement, we zero blood transfusion for our patient. And we record hemoglobin before and after surgery for 6 months, nearly 800 patients. We found that after surgery, the hemoglobin will drop. The maximum is 2 weeks after surgery. And then in 2.5 months, they graduate back to normal. Vital sign is nearly normal. And we study about the fatigue scale. We want to know, the patient also have the fatigue at the 2 weeks after surgery, but they did not interfere with the normal daily activity. So until now for the knee, for example, the patient have a 33 preoperative. We never matching for the knee replacement. And now we use that program to study in the hip replacement. And we're gonna stop matching and button fusion for the unilateral hip also. And this patient, we have to start with the preoperative hemoglobin. And then if they like to do bilateral, we have to matching for that.
Gentlemen, can I have a show of hands? Who uses tranexamic acid in every case? Yep. Another show of hands. Who actually cross-matches their patients for a primary total hip replacement? So we've all stopped. And I think that's a big change in the last few years. Used to cross-match every patient for 2 units. Now with the use of tranexamic acid, group and hold is all we do, and we don't transfuse anymore. Craig, post-op protocol in your hands, this sort of patient?
Well, I would do bilateral hip replacements. I do quite a lot of bilateral hip replacements. I've never had a problem. Post-op protocol would be routine. Patient up hopefully the next day. I do cementless hips. Up walking the next day. Weight bearing is tolerated. Frame, crutches, Clexane for anticoagulation. We do use tranexamic acid intraoperatively, both IV and local. 4 doses of IV antibiotics. That's it.
Can I see again a show of hands? Who uses a posterior approach routinely here for their primary hips? And who uses an anterior approach routinely for their primary hips? And a direct lateral approach? That's everybody anyway. Superpath? Okay. So, this patient, I did discuss with her the role of bilateral total hip arthroplasties, and if someone walks into my clinic, I usually talk them out of the idea of bilateral. If they come in a wheelchair, I think it's a reasonable discussion to have, and I would have been prepared to go ahead, but her financial, social situation was difficult, having just arrived in the country, so I ended up putting her on the waiting list, which takes a year, but she didn't want to wait that long, so we went ahead with one side first in the private, and then a year later we went ahead with the other side. And she ended up a year apart having bilateral total hip replacements. Again, primary cementless acetabular components. They were mostly covered, they were certainly secure. I did use a couple of screws to augment. I don't routinely use screws. Femoral components was a cementless taper wedge prosthesis, which I now use routinely. Our aim is to get them up. We do use tranexamic acid. We don't transfuse. They do get up the same day now, and they weight bear as tolerated. You may see a few beads there. That's because she was part of an RSA study that we ran, but she's gone on to do very well.
Can I just make a comment there,
Certainly.
Rami? If you go back to your x-rays, you put ceramic on ceramic implants in there, so the acetabulum is critical, and you've got a good position of the acetabulum. But if you're using a hard-on soft bearing, then you don't have to put your acetabulum at 45 degrees or less. You can make your acetabulum a little steeper if you feel that it's not actually getting a good fit superiorly, and then you can put in a hooded plastic liner which will accommodate that type of hip.
And have your hood superiorly.
Have the hood superior, yeah.
Good point.
Rami, these were standard after the stamps?
This is, well, this implant gives you the ability to use standard and higher offset. I can't recall whether this was a standard or higher offset in either case.
Okay, and you didn't have to add any antiversion to the cups, because usually these patients have
But
enough antiversion.
I will
just
say
match it.
that, who mentioned, I think it was Vijay mentioned, I have the ESROM on hand with these cases because there may need to be a version correction. So although I plan to go with the standard, the ESROM is available just in case. And certainly with the more extreme cases of dysplasia, I'd use an ESROM, and we might get to that. So here we have a 48-year-old lady who presented to see me. You can see she's already had previous surgery for dysplasia many years ago and presented with increasing symptoms on that left side. So just quickly, we might start with you, Craig, your approach in this particular situation.
Clearly, there's a leg length discrepancy. She needs a hip replacement. I think, you know, you need to bring the cup down to its natural position. You may be left with some uncovering. I don't mind taking the femoral head and using an eyebrow graft. I know it's not structural, but it does give you good initial cup fixation. If you're medialising the cup, you should have enough bone to get good bony ingrowth. I would use a standard biplanar wedge on the femoral side, and I'd ignore the wires unless they're in the way.
Tananet, retained hardware, it's a problem. Any tricks to get around retained hardware?
Yeah, we're not concerned with this have a not infection before. But for this case, we have to talk with the patient that maybe the length after surgery will not the same. And second, the patient usually have some limping because they call the reconstruction for the long period. So after surgery, the patient going to have some limping. She have to know that the patient have to know about the deficit before we do the surgery. And we're going to screw the head and reconstruction the hip. Yeah.
Mm-hmm. Thorsten, at what stage do you consider shortening osteotomy in that case as a dysplasia?
I would not consider in this case a shortening osteotomy because it's 2.5 centimeter about. So I think you can solve this leg length discrepancy in a normal way. But if I go more than 3.5 centimeter, I always consider shortening osteotomy. I do it subtrochanteric. And regarding retaining the hardware, if there is any hardware in and it doesn't disturb me, I let it in, of course. I do not try to remove it. And I would use a normal uncemented stem, uncemented cup.
Gary, when we bring a patient down 2 or 3 centimetres, we start to get a bit twitchy about the sciatic nerve. Do you do clinical assessments, or is there any role for neurophysiological assessments intraoperatively?
I'll tell you a little story. In my youth, I used to put patients in traction who I thought were going to require shortening osteotomy, or I was worried about their sciatic nerve. And one person I lengthened in traction by just 2 centimetres, and he developed a sciatic nerve palsy. So I've kind of a little twitchy about the sciatic nerve. And I don't use any other intraoperative assessment other than my eye and my finger. And I look at the sciatic nerve, I feel the sciatic nerve. If the sciatic nerve feels happy and is not bowstrung hard across the back of the hip, then I'm happy and I will leave that be. If there's any tension in the sciatic nerve and I'm unhappy, then I'll do a shortening osteotomy and I'll protect them post-operatively with knee flexion and etc. so that the sciatic nerve is protected.
Riaz, I have a colleague who's a spine surgeon, and we discuss issues occasionally. He says in this day and age of litigation, you guys in joint replacement are crazy not to use neurophysiological intraoperative studies. They use it routinely in every case. Is there some validity in that? I don't use it.
We'll have to check the literature on that, but I'm not aware of anything that suggests that we have to do that to reduce litigation. I think it's completely unnecessary. I'm happy to lengthen this up to 2.5 centimetres, and all of us use the posterior approach. We can all it affords us the luxury of actually seeing the nerve and feeling the nerve. I don't think we need to do more than that.
I've got one sciatic nerve. First, has anyone had a sciatic nerve injury in an elective procedure? In the room, has anyone had a sciatic nerve injury in an elective total hip replacement? Those that have had it know it's a devastating injury. And if you have it in a young patient, it's even worse. So there's reason to be twitchy. Gary?
A lot of my patients have spinal anaesthesia, and I'm not sure of the role of neurophysiology in the presence of spinal anaesthesia. But I think that one of the complications that goes unrecognised is a complication following spinal anaesthesia. So occasionally patients with a fairly bizarre sensory loss in the leg that's slightly difficult to explain. You blame yourself because you're the one that's been in there, but often I think there is trauma to the nerve much higher than the region of the hip joint.
So we can blame our anaesthetist
I think that's a good idea. We blame the anaesthetist.
Okay. All right, so you can see here, this was, I think Gary, you said we can keep it a little bit more vertical, and in this case you can see chasing the bone, it's a little bit more vertical. and I've used an ESROM here to ensure that version was correct on that site, particularly with previous surgery. Any comments about that? Anyone do anything different?
Just curious about the metalware there. You took those
I had
pins
to remove
out.
the KYs, yeah, it was just...
And
it
you
was
put-
actually proud under the ASIS, so it was palpable, so it wasn't a hard thing to actually remove.
I would go for a high hip center. And, she's been in short for 48 years. So if you leave her another, 5 millimeter, 6 millimeter short, they never complain. So that's the reason why I think people run into static nerve problems. They try to get the lengths equal. But any chronic shortening, if you leave them, 6, 7 millimeters, nothing will happen. So I use the soft tissue tension and the sciatic nerve tension to determine how much I can lengthen. So I'd go by that. I'll certainly go high hip center, and I will not bring it down to the true center. Yeah.
I must say she was very happy not to have to wear any offset shoes, so she was happy with the leg length.
Yeah, it is one question for the opinion. Usually after hip disease before, the patient gonna have the limping. Is it good idea or not a good idea we use a little bit more offset for this patient? You have any...
Thorsten, any thoughts on that?
Yeah, it has pros and cons always. I mean, if you increase the offset, you can create some other problems. And I think I would go for do not increase the offset so much. I would not recommend it. So because in any case, when I increase the offset too much, because I wanted to give more stability, I created some other problems, and the patients are always complaining bursitis or insertion tendinosis, and so on and so on. So I would not really recommend to increase the offset.
Using the modularity of the ESROM Tananet, you've got the option of actually increasing offset. So I do a soft tissue assessment to decide whether I've successfully done that or not. Based on that, does anyone routinely use an offset guide as part of their primary total hip arthroplasty? Who uses one on the panel? Only 2, so the others don't use offset, or do they use electronic or digital? Craig?
Well, you saw Michael's presentation yesterday on the IntelliJoint, and I think if we can use it, I think it's a great thing.
You use it?
Yeah, I do.
Okay, and that's good for offset and leg length.
Yeah, it's great for offset.
Okay.
One important point I'd like to add that this patient pre-operative X-ray, if you see there's an adduction deformity, and before giving a positioning in the lateral position, I would do adductor tenotomy percutaneously.
That's a good point. Well, carry on, Dr. Mahandi, and because here we have a very similar case with this lady, 47 years of age, painful hip. The question is which hip, and you can see she's got 2 problems there. I'm pleased to say that the one on the left, long term, wasn't the painful hip. It was the one on the right. So just quickly, how would you address these issues? And the leg length problem?
First, I would like to do a CT scan of this patient to look for the acetabular bone stuck there on both sides. And you have to go and do the hip, which is more painful, so that because patient wants that, the patient wants to get rid of pain. And would not like to bring the center of rotation too much to the normals because it has to be, matched to the opposite side as well. So maybe a little superior cup I would accept. Otherwise, right side looks pretty straightforward. Is it a stiff hip or a mobile hip?
Sorry?
Is it a stiff hip or it's a mobile?
She had a reasonable range of motion.
Okay, then it looks pretty straightforward.
It's because she was so dependent on this leg because the other one didn't function very well with a major Trendelenburg gait.
Oh, yeah. But left side looks more challenging.
So the CT scan, obviously looking for bone
Yeah.
and how much you've got in the posterior column superiorly. So you discussed previously the use of femoral head and autografting. Would this be a case where you may consider it?
Right side, it may not require bone grafting because there's a good bone stock. You can just remit more medially and put a cup with a good adequate coverage. Maybe 10 to 20% uncoverage of the cup is acceptable.
That's exactly what I did. I did remedially, as you can see. I did a controlled perforation, bone grafted into it, tried to get peripheral capture, but I still wasn't happy, and you can almost see there that, if I can show it there, just how much of that cup was still uncovered even after medialising it. So I felt in this situation it was better to use the femoral head instead of putting it in the bin and actually put a few screws and autograph that top. So it probably about a 50% capture, but in that circumstance I just augmented it with some bone, particularly because of her young age group. And we used an anatomic stem.
Can I ask a question?
Siri?
What role does that graft do? Because your grab is in the columns.
Yep.
These are all high integrating surfaces on the socket, and they do
Yeah.
grab in about 6 to 8 weeks. What does it do in the long term?
It's a good question. I guess my thought was she's 47 years of age. She's probably coming back to a revision sometime in the next 10, 15 years, hopefully. And she's certainly well down the track now. So when we come back, maybe we'll have better bone stock. So it's just putting back some bone stock. In an older patient, I probably wouldn't have done the bone grafting.
Only thing I would have preferred to put the screws little more in the direction of the trabeculae so that, the outcome is better, uptake is better in that case.
Point taken. You can see here, this is some years after, you can see there's good remodelling of that whole acetabulum around the acetabular component. So should she loosen in another 10 years, at least we've got good bone to work with, hopefully, at that stage.
Gross has also shown that you just put the grafts as a flying buttress, cancel as chips, and compact it like a impaction graft. They integrate as good.
Rami, you didn't do anything with the left hip?
No, I left the left hip well alone. She has no pain, no gain in operating. Would you offer her something in an asymptomatic hip? The leg length discrepancy is a problem, but she's managing with that.
Honestly, I would. I mean, she's got a serious leg length discrepancy. I'm sure she's disabled, if not very painful. There you go. I would offer something for the left side, yeah, certainly.
Okay, well, what would you offer? Say you have a patient because, I've obviously been seeing her for some time, and she's come back, and we have discussed the left hip, but she keeps telling me it doesn't hurt, and she's actually reasonably comfortable in getting around.
Well, if she doesn't want it, then there's a different story.
That's the key,
I'm sure
isn't it?
most of these people do come back, and it's we who discourage them, it's a tough hip to do and all that. But technically possible. If it's a problem, I would do that. Even if it's limb length discrepancy, she has a difficulty in ambulation, even if not very painful, I would still offer something.
Yeah.
But before that, I would assess the abductors here on the left side. Maybe you can do a EMG nerve conduction study to look for the abductors, and you have to tell the patient there's a possibility that she may limp because the abductors are weak when you are doing that hip.
Yep.
There will be shortening, you can't correct entirely because you have to do a femoral shortening. Shortening plus there's a, abductor lurch will be there on the left side.
So you're suggesting we may go through a big process of reconstruction and not leave her functionally any better off? Or leave her in pain?
The patient has to accept that
Yeah,
before surgery.
which is why I haven't operated so far. But point taken. Riaz?
Yeah, you'd be very worried about infection on that left side, and you need to know the underlying reason for why she had that girdle stone. But most commonly we see it for infection. So before you proceed, you'd obviously need multiple specimens, and if you get something positive and you're committed to doing something about it, you might have to consider a two-stage.
She did have surgery for dysplasia as a child, then got an infection, and that was the consequence of it. So I think it was leave it well alone. Okay, so we have this patient who's 59 years of age, had a C-on-C. This is obviously many years ago. I've been doing ceramics now for a long time. I must say I've probably got 4 squeakers over 15 years. And this is a gentleman who developed his squeak 2 years after. This is the old zirconia head with the alumina liner. Who are we up to? VJ, you're a hard-on-hard surface gentleman, and you probably see a bit of squeaking, even though you don't do many ceramics, maybe?
No, I do a lot of ceramics.
Okay. So what do you do with a 2-year squeaker?
Well, it depends on how much the squeak affects the patient. If it is a squeak on every step and it's really a trouble for him, I'll discuss with the patient. Then I'm happy to offer him a revision for that. Yeah.
Okay. He wants to know, is this an impending problem that could result in a major problem for him?
Well, the answer is I'll say I don't know, but if the squeak is a problem at that point in time, I will take him on, yeah.
Okay, so in that case, what would you offer him?
I will revise to a hard-on soft bearing. So I will change the cup, make sure my cup position is right. I'll put a cross-linked poly liner, and I would stick with a ceramic head.
Good. So you'd keep the head alone or just change the head to a new ceramic head?
Yes, that's right.
And potentially a larger diameter?
Yes, that's right.
Siri?
Just for the sake of information, why you change the cup is because you think the cup is a bit less antiverted?
No, The cup is the problem for the squeak. So even if I think the cup is well positioned, I will change the cup again, yeah.
Some of these people come loaded with literature review and the Google on these issues. I think we need to reassure that it may not be a serious issue unless we find some telltale signs. Or if it becomes a functional, sometimes it can be getting into their head. That's the only time probably we need to wait.
You know, Michael Morlock at one of the APAS meetings probably about 5 years ago, he's one of the DePuy engineers, said a squeak is an impending fracture of the femoral head. Well, I haven't seen that play out. Gary, through the registry, can you give us any more insight into that?
I can give you some personal insight because I put in ceramic on ceramic in large numbers in the early 2000s, and I had a considerable number of squeakers. And so I've revised a lot of hips in Christchurch for squeaking, not all my own, but a lot of others as well. If you run a series in a surgeon who does ceramic on ceramic, and ask your patients independently with an independent researcher how many patients get noise or squeaking with their ceramic on ceramic, the figures range from 15 to 30%. All right, so that's what happens. So these joints do make a noise, not all of them squeak. The squeaking, in my experience, can be two types. You can have the squeaking which starts very soon after an operation, and sometimes that resolves. Sometimes that does go away, but often it doesn't. Then you have the squeaking that starts at about 12 to 18 months later. That's almost always secondary to loss of lubrication of the joint. And so you're getting increased wear of the ceramic as a loss of that lubrication. So what you're getting is ceramic wear. You don't actually get ceramic fracture. Femoral head fracture is a rarity, particularly with 36mm heads, even on our joint registry. So my plan for this would be to leave the cup alone. And if the cup is solid, I leave it alone. I put in a plastic liner, just as Vijay said, and a ceramic head.
And the issue of impending fracture, do you think that's a furphy?
I've never seen it.
Good. All right. So, and that's the sort of advice I want to get across. I don't think this is preliminary to a fracture of the ceramic ball. I certainly haven't seen it. I haven't seen it reported, but Michael Morlock has actually described a couple of them. And that could be due to impingement between the neck and the ceramic liner, I think. Anyway, in this gentleman, I chose to do nothing. I've reassured him that it won't lead to anything. He was happy. Of the 4 squeaks that I've had, 2 have resolved. They were early squeakers, and the other 2 continue only in a minor fashion. Once a patient is reassured, it really isn't a problem, so we haven't done anything for him.
One comment, Rami.
Yes.
Does anybody worry about catastrophic failure of the polyethylene from the ceramic wear? And when they used to talk about using a sacrificial poly in there, something that they used to caution us about and saying when you revise ceramic on ceramic, you could only go into a ceramic on ceramic. But clearly that isn't the case when we're talking about revising to ceramic on poly. Any comments on that?
Vijay?
I think that refers to a ceramic fracture and not to a squeaker. In ceramic fracture, certainly I wouldn't use I would try to go ceramic on ceramic again, yeah. Certainly.
I agree. Well, we've got a 55-year-old lady. I've been looking after this lady for a long time. Increasing left hip pain. So I think we're up to Suri maybe, which is very appropriate at this stage. So Suri, this patient you're seeing now, she obviously has had previous revision surgery on each occasion. I might just, if it's I think it's the next one. Yeah, this is how she initially presented to me 10 years before. And she'd had these hips in for 10 years in another country. This was at the beginning of my practice, so it was a good introduction into arthroplasty surgery. Anyway, here's 10 years later. The right side is asymptomatic. The left side is becoming disabling. What are your options at this point, excluding sepsis?
Well, once you exclude sepsis, second is, I would worry about some form of an impingement pain. So try to probably study and analyze what sort of symptoms she has. It could sometimes be from the anterior on the femoral anteromedial side. It could be a hard-on-hard impingement. So if you rule it, because then probably a better radiology and to make sure that we don't have any evidence of prosthetic loosening or a subtle fracture of these cages. Sometimes I think metal fatigue fracture of these cages is not uncommon after the 8th, 9th year. So I think these 2 things should be ruled out. If that is so, then probably she is asking for the next revision.
So would you get a CT scan and do you employ angiograms at any stage in situations like this?
CT and angio would be
looking for the neurovascular.
Absolutely, absolutely.
I know. Mojib? What's the approach in Saudi?
I agree with what Suri said, and I think I'll be concerned that she's getting into either the cage failure. I assume that was an allograft, so usually these do have a high failure. About by 10, 12 years, they have about 50 to 70% failure. I'll be concerned about pelvic discontinuity, which probably will show up on the CT scan.
Yep.
And then depending on the integrity of the columns and the degree of bone defects, the way to go will be, once you, maybe the radiologist will be able to take away the metal by their software. It will give you an image of the degree of bone defect. And I don't know, this seems to be a huge defect. So one of the ways to go around is either to use the tri-flange, the custom-made tri-flange component. The others, and again, depending on the severity of the defect, is to use those shims that will bring down the center of the acetabulum down, and then you can use one of those porous tantalum revision cages. But that will be entirely dependent on how much of posterior column is intact.
Okay.
Study of the serial X-rays will give us an idea
Yep.
if there is a medial migration.
Yeah, and this is what I'm trying to give you here, and that was an earlier film here, and then this is a progressive film a couple of years later. And you can see what's happening with that Birch-Schneider cage. It's slowly hinging on the iliac wing. So it's not actually broken, and you can see the screws are still intact, one's maybe backing out, but it's just hinging, and it kept hinging until it actually sat on the SI joint. So Craig, your approach to this, big deal, and we've had some great presentations today this morning, so there's some good knowledge all around, but how do you actually approach this particular problem? And there it is sitting on the SI joint.
Yeah, as you say, it's hinging, it's moving medially, the inferior part's moving medially, so it's loose. Needs CT assessment, 3D CT, metal subtraction, 3D pictures if possible, and that looks like it needs a patient match implant to me. I can't see any other way to reconstruct that. That femoral component, is that a modular head?
No, it's not. It's a very old Muller by the looks of it, I think.
Great.
Yeah. So that's another question. What do you do with that?
I think you probably have to do a patient match implant on the acetabular side and revise the femur.
Yeah.
I think it'd make it too hard to deal with that femoral head in situ. I don't think you'd get it out of the way.
Tananet, in Bangkok, what do we do?
So if the cause of pain is from the acetabulum, so we're going to change the spotting link. Routinely now we use the allograft. We have our own deep frozen allograft. So we're going to pack the bulky allograft in, and we're going to apply the new supporting case for these cases. And in case we have to prepare for the revision of the stem also. If we can do the allograft, supporting case, and everything fine, we not revise the stem.
Not revise the stem. One of the problems, however, when you do a major acetabular reconstruction is you end up putting it where it needs to go. You don't have that control for offset length, etc. And with a fixed monoblock, it becomes very difficult then to adapt, and the risk of post-operative instability and dislocation becomes very high. So I think sometimes you're forced, unless you've got a modular head, to actually revise the femoral component. Thorsten, what are your thoughts on that?
I have the same thought. So I think this situation is not too bad. It seems that there is some posterior support still. So I would go for an allograft, and I would fill up the defect in the medial part, and then I think I would go for either a jumbo cup fixed with a lot of screws or a cup and cage system. The question is really, should we revise the femur? I have the tendency to do this, because it's easy to remove. It's the old Müller banana is quite short, so you can get out the cement from the top. So probably I would revise the femur as well.
Good, because that's what I did. So basically, getting the component out was a case of removing all the screws. Took a little while, but we eventually extracted it. Of course, your scrub nurses are always very happy when the hardware comes out initially. And then we used a lot of bone graft, created a new bone bed with allograft. used a highly porous titanium. This is a Regenerex shell. It was actually 80 millimetres as a scaffold. Because of its roughness, it actually gets a very good hold, but it's not enough on its own, so we set another birch Schneider over that and cemented an all poly cup into that. And we also proceeded with a femoral revision just to optimise really our offset, decrease the risk of dislocation. And I think bone grafting extensively is what's important here, not for the short term, for the long term. And when I reflect back, I look at what I did on the right side, and that's gone on to 15 years, now 17 years, and is still stable. So it's all about how much bone graft you impact there. And had I done that on the left side, I mightn't have had to do this revision. But here we are now 7 years after the fact, and she's still walking around on both sides with minimal. She's got some back symptoms now, but no actual hip symptoms. So Thorsten, this one's specially for you because you've presented on the TM cones and cups and augments, and I think Michael made a very good point in that. And I too, I don't use them because I have a concern and a question mark about the fusion of the augment to the cup. And this is one done by a senior colleague, the founder of APAS, 6 years prior to its representation. So you must have seen some of these. Can you talk us through the thought process of how you go about dealing with that, and what's the solution to stop this dissociation happening in the first place?
So if it is a progressive migration, what it is, obviously, we have to remove the cup, we have to remove everything. And then you have, again, it's all depending on the support, as I mentioned in my talk. If the posterior column is quite intact, I would go also for medial, some kind of impaction grafting or a cup and cage system, and for jumbo cup with a lot of screws. If there's no posterior support in this case, because it's obviously a 3B defect with a pelvic discontinuity, I guess, I would consider an individual 3D printed implant. So, yeah.
So getting back to the dissociation between the cup and the augment, how do we minimise that risk when using this system? Do you cement between the two, or do you pass screws through the cup into the augment, into the bone?
This is exactly what I do. I screw through the cup and the augment into the host bone, and you can. Sometimes you need to drill new holes into the cup, which is possible with a high-speed burr, and I think that's the best method to fix both.
And do you put cement as a layer between the two? Because that's the recommendation, isn't it?
If I have an augment and a cup, I have to always to put a cement layer in between it.
Okay. So Gary, any thoughts? Your approach?
Yeah, well, that's obviously a difficult problem. I'd want to check it's not infected to start with. That'd be my overriding concern. I'm a little worried about the other hip too, to tell you the truth. So in my hands, this would be a custom implant. I do a CT scan, and we make custom implants in Christchurch on the spot. So that I've got ready access to that. And
do you have a 3D printer at the hospital?
Yep.
Wow.
We have a 3D printer at the hospital that doesn't make our custom cups. We have a 3D printer that's down the road that makes the custom cups. Okay. Yeah, that and getting back to the thing you mentioned earlier, what you can do with your 3D printing is that you can, when you're planning it with your CT, you can actually plan offset and leg lengths with that, and so that the implant goes in exactly where you want it to go once you've discussed it with the engineers. So so we're quite privileged in the fact that it's on site. So that's what I'd do.
Riaz, do you have any different approach, or anyone else have a different approach?
No, I think Thorsten's point there that if there's adequate bone, then consider the cup cage construct, and if there isn't, then I think you've got no choice but a PMI. With the PMI, and just same also with the cup cage construct, we're now lucky enough to be able to get trabecular metal and highly porous implants made. And I think that's really critical, because if you're going to put something in, you really want to get ingrowth into it. And I think that's why the earlier cages failed. So I think really good look for something that's porous.
And look, that's exactly what we did. We excluded sepsis, we assessed the bone stocks with CT, enough to tell me that I didn't have sufficient bone stock to actually do the same procedure I did in the last case. I planned the revision using PMI, using CT technology to determine the reconstruction technique. I selected that implant because it was available to me. Cost is an issue, there's no question about that. You've got to realise it does cost about $15,000, so you've got to take that into consideration, particularly in areas like this. But as Michael gave an excellent presentation on his case series of 13 patients, I think it was, it is a means out of a very difficult situation, and if you take into consideration the cost of the acetabular reconstruction cage, plus 3 or 4 femoral heads, plus the other things that go with it, the cost equivalency is very close, particularly if you can guarantee a more successful outcome, and his series certainly seems to support that. So we did all necessary studies beforehand leading up to this. The transition phase, if you don't have a printer on site or in the city, is somewhere between 6 to 12 weeks, so it does take a little bit of time. But nevertheless, you get good images that you can study, you get a 3D printed model that you can have intraoperatively to feel and play around with to make sure you get the orientation right, so your exposure is sufficient to be able to seat the triflange cup in the position that it was meant to go in. The iliac exposure is fairly straightforward. The ischium, as it was said, is more difficult, and the pubis, well, you just got to feel it. And in the couple that I've done, one I was able to get a screw into the pubis, the other one I wasn't, but I sat it, and it just sat very nicely. So both do sit in the right position once you get it in place. And this lady unfortunately had a femoral nerve paresis post-op, but fortunately after 6 months it completely resolved. And she had a good outcome, enough to actually bring her back, as Gary's kind of highlighted, sometime later because of concerns about her other side. Vijay, actually Dr. Mahanti, what would you do on the other side?
Before going to the other side, I just want to give one message for our delegates that before taking out this cup, one should do a CT angio as well, as Shuri told you in the earlier case. And we have to keep the vascular surgeon standby in case there is some problem.
Yes.
And second point is that 3D model is now available in the city of Mumbai. You can get it by sending your CD, 3D CT, and you can get it our courier. They courier it to the model so that you can plan your surgery well. There are two.
What's the cost here?
It costs around 10,000 Indian rupees.
He's talking about the implant, not the 3D
No,
model.
3D CT.
The implant, the triflange cup here.
No, implant.
No, we don't have it in India. No, we don't have it.
Oh, sorry, I thought. Okay.
Now, Rami, one point. Michael also mentioned that there's a concern of dissociation of the cup from the trabecular metal augment. We haven't seen it. I would like to see the Thurston. Do you see that commonly? The cup coming off from the augment, like this one.
To be honest, not very commonly. Yeah. To be honest, it's quite rare in my experience.
I'm surprised that two surgeons from Sydney said the same thing, but we haven't seen that at all. Yeah.
I had one, but at the time I wasn't cementing the cup to the augment. But ever since I've started doing that, I'm not seeing that.
That's why I wanted to elicit the technique, whether there's a technique deficiency, and what is important, whether getting screws across or cementing just makes that bonding a little bit better.
I think the way we put the augment again, whether you use it as a wedging construct, you get the augment fixed and you wedge the cup. What is important probably at the same time is to see that you have some host bone contact on the socket. They have to integrate. You can't depend as a permanent measure, then they rip apart. And if you don't have it, if you just put it right on top, then it's a problem of dissociation. With regard to the recommendation of cementing the two to unitize the concept, I think it's been a flip-flop. Initially they recommended, then they said it's not necessary, then it's going back. So I'm not really certain what is the way to go. I think what is important is the wedging of the thing.
But the thing is, the cup for when you put a porous tantalum augment, the cup will be going more like from outside to in, whereas the screw from the augment, whereas the screw from the cup will be going more into the ilium. So they'll be crossing their path, and you won't be able to put you won't be able to put a screw from the cup through the augment to the bone. What you can do is you put a new hole. Right, or you put a cement in a very doughy seat like a simplex, and then as it dries, you fire your screws in.
Now, the other thing, if you're removing this, is the highly porous construct not only gets good bone ingrowth, but it actually gets excellent soft tissue attachment. And that is a real problem when you're extracting it, because you can cause neurovascular injury. You have to peel it away very carefully to avoid further damage iatrogenically. So look, I might just pass on this one. This is, obviously we had to deal with the other side. I wasn't prepared to do a triflange cup on that side. I thought we'd get away with a much simpler procedure. The one thing I was concerned about here, and I want Craig maybe to comment on that, is we've got metal on a very long, well-ingrown monoblock femoral component. Is there a trick or a way you can think of to avoid revising that femoral component, which I think would be a bit of a problem?
Did you say that's a non-modular femoral head?
Non-modular, yeah.
You've inherited a few of these, right?
Yeah, look at that.
Well, you just got to do the best you can to, extract that and, try and protect the metal head, try and work around it, get the cup, but if it's not working, it's not working. You have to change the stem.
I'd certainly try to avoid that.
It's a very long neck and it's going to be in the way. You create the usual pocket and try and rotate it out of the way, in front of the acetabulum, but...
I guess my concern wasn't, I could get it out of the way. My concern is because of the metal impingement, how much wear of the metal head are we willing to accept before having to extract it?
Oh, so, I see where you're going.
Yeah, how much damage are you willing to accept?
Well, you're going to put it into into polyethylene, right? So you can accept some visible wear, but not deformity. That's my view. If it's deformed, you have no choice but to change it. But if it's a bit of visible wear, that's fine.
Tananet?
I think to remove the full coated, very fitted is very terrible one. When we have to remove it, we have to do OrthoTV down to the tip, because even one piece of the metal contact the bone is very firm. I have the other idea. So we have to accept some sketching of the femoral head. I have 10 to 12 years of the cemented cup in the shell. Very good one.
Okay, so I guess what I wanted to get across is, look, I did a basically jumbo cup revision with bone graft, and that went fairly well. And then I was faced with a femoral head that I couldn't remove because it was non-modular, had a little bit of damage on it, and the only way I could think of getting around without removing that entire component was to put on like a dual mobility, or I put a bipolar head into a polyethylene liner. I figured that will decrease the stress through a double articulation, and hopefully that will be a long fitting. So Gary, what do you think? Is that a reasonable compromise, do you think, or am I taking it the easy shot?
It's called the art of orthopaedics, Rami. You have to... how old's the patient, what disability he's got, what does the patient expect, etc. So I think you've got yourself out of a deep hole there, and I think that'll work. We see this more commonly in knee replacements when the femoral side has been rubbing on an exposed tibial tray, for example, and we do accept some burnishing of the femoral component on our polyethylene, particularly in older patients, and I've not really seen a major issue with that.
Yeah. I think it's a compromise, and sometimes you do have to compromise for the benefit of the patient, if nothing else. So we've got a 70-year-old male here. This may be the last case. 1 year post-left total hip replacement. This is taking a slightly different tact. So you can see here we've got a beautiful metal-on-metal articulation, which Vijay, I've got to tell you, was asymptomatic. So he wasn't a problem on the right side. His problem was actually that left side. Onset of groin pain, pain on ascending stairs, pain on getting into the car, pain on straight leg lift. This was a painful post-operative event that he wasn't very happy. And I did this hip replacement. So I've seen a couple of these. Anyone with some thoughts as to what's going on here?
Excluding sepsis?
No sepsis, aseptic.
Okay. Could this be impingement?
Well, that's what I'm asking, yeah. So how do you go about assessing that?
Is there osteolysis on the super aspect of the acetabulum?
No, that's it's just imaging.
I can do a CT then.
It's a good point.
Depend on the getting to the car. I have 2 cases. They have eroso and impingement. Very specific when the patient try to get in the car.
Yeah, that's exactly right. So how do we go about actually confirming our suspicion that that may be the problem?
Injection.
So inject what?
We're going to do under ultrasound.
Yeah.
We allow the radiologist to inject to the tendon.
Just the iliopsoas bursa?
Yeah.
Steroids or local?
I think we have to do both steroid and silocaine. We're going to prove the symptom and going to treat that patient also.
Well, that's what we did. We injected him. He got good relief for about 5 to 6 weeks, and then it started to come back again. It confirmed in my mind that he was getting impingement. I looked for evidence of loosening, evidence of lysis. I couldn't see anything to convince me that he had a prosthetic implant-related interface complication. I think it was a soft tissue complication, which on physical examination seemed fairly consistent. And I didn't rush in. I waited for about 6 months, but there was no question he needed something done. So the question is, to the panel of experts, what do you do?
I think once you've been injected it once and you've confirmed the diagnosis, then I would always go for a second injection. And if that occasionally works, and if it doesn't, then I'll proceed with a psoas tenotomy and get reasonable results with pain relief with the psoas tenotomy. Failing that, of course, you have to revise the cup.
So psoas tenotomy, what do you do, a medial approach and just tenotomise the tendon, or do you do it arthroscopically? How do you do it?
No, I just open up the distal part of the wound. I use a posterior approach, just internally rotate the hip, and you'd be amazed at how the less trochanter just presents itself. You don't go anywhere near the hip joint itself.
Well, why not come in from the medial side? It's a direct approach.
Oh, that scares me. I'm very happy to go around the back.
Okay, all right. Thorsten?
I would also go for a revision from posterior approach, because what I have seen in my career is a phenomenon of arthrofibrosis of the hip in some cases. So what we see in the knee more frequently, of course, you can see it sometimes in the hip, that the whole joint is full of scar tissue. It's some kind of I call it arthrofibrosis of the hip. And then you remove it, you make a release of the psoas, and the patient are pain-free from the next day. So this is sometimes a good solution.
Mm. And Gary, you got some comments there?
Just on the initial workup, I think if I see someone in my practice with a metal-on-metal implant and they develop pain a year down the track, I'm worried about soft tissue masses.
No, but this is the other side, so it's not the metal side. This is the ceramic on ceramic side.
I thought there was a metal on metal.
No, that's why I said to VJ, the metal side is actually doing very well.
Sorry.
So this is ceramic side. There's an MRI that actually showed a bursitis around the iliopsoas tendon. There's the bursitis there. That's the area we injected. He got a response. It was enough on clinical grounds for me to actually offer him, as Thorsten said, a full revision of the acetabular component, anteverting it more so the metal part of the implant sat beneath the anterior rim of the acetabulum. There was scarring in that area which was resected, and it did resolve his pain. I've done 3 of these now, and they get instant relief of their symptoms. The key is making the right diagnosis. But I do have some arthroscopy colleagues who tell me they can do it arthroscopically to release the psoas tendon. I get a bit jittery about them doing an arthroscopy on my hip replacement. I don't know how you guys feel.
Yeah, I was going to ask you that, if you'd considered that.
Would you do it, Craig, arthroscopy?
I've given up doing hip arthroscopies, but I would consider sending it to a colleague to do. If there was a paper a couple of years ago where about 50% of these could be fixed with psoas tenotomy and the rest needed a cup revision.
Yep.
There have also been a couple of deaths from arthroscopy, with pumping too much fluid into the psoas sheath. Yeah. It goes all the way up to the chest.
My concern is you're not actually attending to the problem, which is the anterior aspect of the acetabular component being prominent.
Do you release the psoas tendon when you do your revision?
No, I didn't actually. I just moved the cup so it wasn't impinging on the psoas at all and just debrided the area of scar tissue anteriorly.
But revising is a much more extensive procedure than
no question about it.
Why didn't you consider
tenotomy?
Addressing the iliopsoas tendon?
Yeah, well, I thought, look, I'm going to actually attend to the problem. It's a good question, and this is why we've got a panel of experts. Who in the panel would just do a tenotomy, just out of interest? Everybody except me. Okay.
So doing your primary hip now, do you make sure in every case that you don't have any uncovering at the front?
We discussed now that we try to have a look at that anterior rim of bone and make sure that you've got to make sure, careful with aversion, but just make sure you've got a little lip of bone anteriorly, you're not prominent if you've got good vision.
Even if it means changing, anteverting your cup a bit more than
a little bit,
with, and you're happy with a bit of posterior prominence?
Posterior prominence doesn't seem to be a clinical issue.
I agree, doesn't seem to be.
So it's not a problem.
So just a comment, routinely, I don't think people do iliopsoas release for routine total hips, but in sickler populations, a lot of them come with contracture. So I routinely do the psoas release for them, and I haven't had a problem of impingement in that particular patient population.
Yeah, it's interesting. When I first started practice, which is a long time ago now, the entire posterior approach incorporated automatic release of the psoas tendon, which we no longer do now. So, all right, well, I think that's time. Gentlemen, thank you very much. Excellent response from the experts. Please thank our panel of experts for their